So for those of you who have joined us, my name is Nicola Hobby. I am a senior director here at BAO Systems. And today I am excited to be moderating this session with our esteemed colleagues from the WHO, Global Fund, USAID, and PEPFAR in a focused discussion around how these agencies have not only supported DHIS2, but in some cases used it for their own reporting purposes. So with that, I'm going to do a very short round of introductions, starting in alphabetical order. Joaquim Andreas Blaya is a senior health advisor at the World Bank who focuses on national scale digital health projects. Hello, Joaquim.
Hi, everyone. Great to be here. So yeah, my quick intro. I've been doing digital health, most starting from an implementation and evaluation, starting about 15 years ago. And then, joined the bank a couple of years ago for exactly what Nicola mentioned, which is the promotion of national scale systems. So it's time to go, beyond the pilots, and so I've been here for about 2 years in this division that focuses specifically on those programs.
Great, thank you, Joaquim. Jacob Buehler is a senior strategic information advisor and the health informatics branch chief for USAID, the Office of HIV and AIDS, and welcome, Jacob.
Welcome. I think my bio is there. Happy to defer to that, but really excited to be on the panel. A lot of new and old friends here.
And Mark DeZalia, Information Systems Team Lead at the Department of State for the Office of U.S. Global AIDS Coordination and Health Diplomacy, specifically on the PEPFAR team. I've had the pleasure of working with Mark for nearly 2 years as the former Datum product owner, and I'm thrilled to see him here again with us today. Hello, Mark.
Hello, Nicola, and everyone. Thanks so much for having me. Just like Jacob, my bio is available. I'm pleased that I know a lot of folks in the audience, but also very excited to see there are a lot of names I don't recognize. So really looking forward to this session. Thank you.
And finally, Michelle Monroe is a senior specialist for the Monitoring and Evaluation Country Analysis Team, Technical Advice and Partnerships Department at the Global Fund. Welcome, Michelle.
Thank you very much. Looking forward to the discussion.
Great. So yes, we're friends, we're colleagues, we've known each other for a while. You guys have been circulating within the DHIS2 community, but you also happen to sit in donor agencies, which makes you very special people. Not only because you have a particular insight into how national systems work, but the intersection between DHIS2, and in some cases, your agencies are actually using DHIS2. Mark knows this very well as this prime systems lead. But just really briefly, let's go around the room very quickly because we have a lot to get through. I might cut you off if you go long. Don't take it personally, but just really briefly, talk to us a little bit about either how you are directly involved with supporting DHIS2 within your agency, or indirectly supporting DHIS2. And Jacob, because you're on my left, I'm starting with you first.
Sure. Well, thanks, Nicola. Maybe just to really start off, I'm standing on the shoulders of giants here. I've been involved with USAID since 2013, but USAID's involvement with University of Oslo and NORAD really traces all the way back to the late 1990s. I think Management Sciences for Health had a project called the Equity Project funded by USAID. And this was for the broader implementation of DHIS 1. I don't know if it was 3 or 4. So USAID has a long history supporting and engaging on DHIS or DHIS 1 or 2 implementation. I would say that by and large, however, our investments have been quite diffuse. So across many, many different programs, health areas, primarily from a aggregate level reporting for health management information systems. I'm going quickly, Nicola, I promise. fast forward to 2015 or 2014 or so, and we started working within the PEPFAR ecosystem of gathering and collecting data through Datum. So I don't want to steal any of Mark's thunder here, but we had been involved in that work. And then really as the ecosystem or the platform has evolved with DHIS2, we're seeing a lot more implementation supported by our partners looking at individual level data collection through the Tracker Capture app and solution. And I think we'll get into this in the panel, but really looking at program specific areas like orphans and vulnerable children programming through HIV, adolescent girls and young women prevention activities, and what we call dreams layering, as well as sort of broader case management activities served through DHIS2. So again, we've seen a lot of different areas in which DHIS2 is being used by partners we are funding and supporting, and the host governments that we're engaged in as well. Over.
Thank you, Mark. Oh, sorry. Thank you, Jacob. So Mark, I'm actually going to go to you next. To sort of tie along on the U.S. agency side.
Absolutely. I think Jacob said it well. We're all standing on the shoulders of giants here. There have been certainly a number of use cases of DHIS2 at a variety of, I think, smaller scales in some of the agencies that are involved within the PEPFAR program. But my predecessor in this role, Mike Garon, very early on, saw the opportunity for engaging with the University of Oslo directly and using the DHIS2 software for what our former ambassador of the program, Ambassador Burks, we knew there was going to be a big focus on facility level data collection and that spreadsheets weren't going to cut it. And so we started that partnership with the University of Oslo. I think our eyes were wide open, but Jacob was part of the team there as we approached the deployment of that of the software, and we learned a lot of things that we would never do again, as well as I think a lot of things we would recommend that people do as well. And I think that's so important as we talk about DHIS2, that it's the software is so much focused on how it is implemented, how it is used within an organization. And I will say that has evolved within our program. But what I think the reason we had success with adoption is because of the notoriety of the program. And as Jacob said, our implementing agencies, many of our partners, many of our partner Ministry of Health colleagues were familiar with DHIS2 and or were already using it for a variety of use cases. So that certainly limited some of the resistance barriers, not all of them at first, because I think it was really tied, as most deployments of software or systems are, with some organizational change. And so sometimes as implementers, you get caught in all of that. I think as Jacob said as well, there are a number of use cases at the country level as well that our implementing agencies and partners are using. And these, I think, are already being well described in some of the other sessions that are here as well. But yeah, we are grateful for the opportunity to continue to provide sort of core software support to the University of Oslo, as well as using the software for our own purposes. And I will say, just sort of in closing here, we maintained as part of that core software funding agreement sort of the red Lars button in case we had an emergency. And it is really, I think, a testament to the maturation of the software development processes, the testing processes within University of Oslo, as well as our own, that we rarely, if ever, need to use that sort of escalation pathway. Thanks.
We have a Lars red button as well, so we know that well. Michelle, over to you.
Sure, thanks. So at the Global Fund, we have, I'd say, two main ways that we interact with DHIS2. And the main one is, of course, Global Fund is mostly about giving grants for HIV, TB, malaria, and now C19 to countries, including their national programs. And this is based on the national programs and the governments putting together through their country coordinating mechanisms, CCMs, requests for the funding that they need aligned to their national strategic plans. And so these country grants is the bulk of Global Fund funding. And we fund over 100 countries, but within that, there's 50 countries that are what we call high impact and core countries. And these are countries that have the highest bulk of funding because of also having the highest disease burden for the 3 diseases. And so we fund a lot of different digital systems that countries request, and Global Fund has historically particularly funded a lot at national scale for both aggregate and patient level programmatic data systems. So we fund a lot of different software, but in those 50 countries, for example, there's 44 of them that use DHIS2 as their national HMIS. And then looking forward with Tracker, there's many already using it for their patient level HIV, TB, and even malaria reporting. And we see, just in the newest round, we have just in that subset of countries over 30 requests for funding for DHIS2 Tracker for HIV and or TB. So most of what we're doing at the Global Fund is funding the national data systems, which in so many cases are choosing to use DHIS2. But we do also have a small amount of central funding that we do because of the fact that so many of these countries are using this one system. And so we do have some additional core support to DHIS2. For core software development, but also so that there's things that countries, that are not likely to be funded in the country grants that countries may not fund that can cross-cut, and also looking for efficiencies so that things don't have to be developed over and over again in each country, and also around a lot of the local, regional capacity building. So those are the main areas that we're focusing on in regards to DHIS2 at the Global Fund.
Great, thank you very much. And finally, Joaquin.
My response is much shorter because first, the bank is highly decentralized, I think even more so than, very similar model to the Global Fund, but, country teams really, the ones that have the large bulk of funding, and there's almost no centralized funding that we can provide. With that said, very similar experience with Michelle, where a lot of the countries that, where at least our team, which is kind of this internal consulting team within the bank, has been engaged, there is a DHIS2 presence that is part of it and continues to grow. And just to say that, part of the reason our team exists at the bank is to continue to accelerate this, because the World Bank is very conservative, especially when it comes to digital health, and we'd like to change that.
Okay, excellent. So we're going to move on. We're going to go a little bit faster because we have so many questions to get through. But I want everyone to put on their Lars Overland hat right now, which is usually I think a baseball cap. And think about, or what do you feel like DHIS2 has done well, and where are there areas for improvement, whether that is a specific software feature or something within the broader community itself? Who wants to go first? Joaquin?
Sure. Yeah, happy to. So I think software-wise, interoperability, DHIS2 has done it well, but I think it needs to do it better. Or needs to do more of it, and more countries are looking for interoperability with, without that much knowledge of what it means, and so we need to make it as plug and play as possible, knowing how hard that is. And then standardized indicators, I think, would be great, to be shared, or ways to share those indicators between countries, some sort of standardization, and then The final thing I'll say, which is not software related, is more focused on middle income countries. I think DHIS2, right, is in terms of low income countries is pretty much everywhere. I think focusing Latin America, for example, and other kind of middle income countries, which will require better, more flexible software and other things, I think would be great, because especially in Latin America, open source is such a bad, a wrong, interpretation or history about it, that I think something like DHIS2 could be pretty significant.
Yeah, that's really interesting that you mentioned the middle income countries. I don't know if you caught on, but Norway has actually adopted DHIS2 for part of its COVID surveillance. And 116 health municipalities across Norway. So you're right. And Lars was saying in his welcome remarks, like, yeah, this there's a case out there for this to be said, that it's not just for low income countries. Jacob, I saw you nodding your head vigorously when we talked about indicators. With your Overland hat on, what's going well? What do we need to improve?
Well, again, I don't want to steal any thunder from Michelle and others who I know are really thinking about, how do we really kind of solve this issue? But it's been a pet peeve of mine for quite some time that, we give host governments an extremely powerful tool to establish their own data model. And it's challenging because each country develops their own very special data model. And that can be problematic when we want to look at public health data as a global public good. Mark knows this well. I'll just leave it at that because I want to make sure that we have enough time to talk about other things. The only thing that I will say, and maybe this is a cop-out, there are lots of things that could be improved, but I think University of Oslo, the HISP approach, and really focusing on, say, the HISP UIO integrated master's program, all of the ways in which we've actually focused on capacity. I will say that this is really sort of the secret sauce, if you will, which is that you have many, many evangelists who are really willing and prepared to leverage the platform to really extend it. And I think we'll talk about that maybe in this session a little bit further. But I think that's one of the key important things. But agree with all that's been said thus far. Over.
Okay. Does anyone else want to go? Otherwise, I will move on, because I love that we're talking about standardized indicators, and I think that's going to come up. Mark, do you want to give your thoughts for 30 seconds?
Yeah, I'll try to. I agree with Jacob entirely. I think DHIS2 and UIO generally and HISP have done a very good job of building a brand and a community. I think exactly as Jacob said, one of the strengths of DHIS2 is that it's very easy to start and do anything you want. And one of the weaknesses of DHIS2 is very easy to start and do whatever you want. And then there's an expectation that you can change quickly and add new things in. And so just to build on what Jacob was saying specifically about interoperability, and I think we might get to this a bit later, there's a lot of interest in there's the COVID metadata packages that came out this year that Norway also used, I think is a very good start. I know at WHO, they've done a lot in a number of key areas of developing those metadata packages. But there's a behavior change that needs to happen in other organizations, my own included, in the way in which we are articulating our guidance and making sure that we're not essentially shifting a burden to thousands of downstream partners and ministries to reinterpret narrative guidance and program that into the computer and into their program. So I think there's a lot more that we can do in that space, and that's not all on DHIS2 at all. I think a lot of those that should be platform agnostic, frankly, and that gets to one of Joaquin's points as well. Just I think yes. There are ways to use DHIS2 in other environments. We've done that, but it hasn't always been easy, and it certainly wasn't out of the box. And so I think really getting behind core data exchange standards like we have within the Office of the National Health IT Coordinator in the United States, very much around FHIR. I do think that is the future, and making sure that the way in which we're writing our requirements, the way we're releasing our guidelines are aligned with standards that are being uptaken and applied in a variety of different platforms, particularly if we're supporting them, right? We should really be thinking about that full ecosystem. Over.
Yeah, so actually, you know, we talked a lot about Tracker, both at the national level, but actually there are a couple of examples of even the agencies using Tracker. Jacob, you touched on it with the DREAMS and OVC systems. For those of you who are not familiar with the DREAMS and OVC programs through PEPFAR-funded countries, these are interventions that are designed specifically for a target set of beneficiaries, specifically women and girls of adolescent sexual reproductive age, and also orphans and vulnerable children. And the idea is that you're providing them with a package of services or interventions over time. And therefore, you have to be able to identify this individual and then be able to associate these services with those individuals throughout that. And Jacob, some of the USA country missions have been building this data collection, reporting, and repository on DHIS2. How has this been going? These are incredibly complex setups within the DHIS2 architecture. What have been some of the challenges that you guys have seen?
Sure. Thanks, Nicola. I mean, maybe I would categorize sort of what we've seen into sort of three main challenges. Again, focusing on the challenges doesn't mean that DHIS2 isn't serving its purpose and is not meeting the needs. But I really think that the push and drive towards individual level data collection, especially if I'm really being honest, in service to reporting, as opposed to in service to quality of service, it is a challenge. You know, I'll raise my hand. You know, I'm trying to be part of the solution, but I'll freely admit that PEPFAR and its implementing agencies are somewhat part of the problem. Let me just start off by saying, I think the first main challenge is the complexity of indicators and sort of the evolving reporting requirements. So really just kind of, you know, picking up the ball that Mark, you know, passed off and running with it, which is that as indicators shift over time, as expectations around how we are sort of tracking individuals longitudinally, what these minimum packages are, how we define them, are they standardized or are they somewhat bespoke? That becomes really challenging. And while tracker capture and the sort of the model of using tracker capture for this type of data collection, you know, it works, but as you evolve those requirements, things change. And, you know, to be quite frank, I'm not convinced that DHIS2 out-of-the-box analytics can always actually meet the demands of that. Second, really quickly, is just the user interface and audience segmentation. So, you know, we're doing this in Botswana, Zimbabwe, Lesotho, many countries, that just to name a few. It's really important to understand how DHIS2 tracker capture is being utilized for that. Is it really just the central data store for all that individual level data that's getting collected through different means? Is the intention that the actual case manager, him or herself, is keying things into the Android app? And so when you think about all of the various individuals part of sort of the data acquisition chain for this, you know, DHIS2 tracker capture may be better served for some audiences and not as well served for others, and may not be fully optimized, whereas other mobile health solutions may be more optimized for a case management scenario. And, you know, just to be sort of open and frank, I think that's something that we're learning to adapt with. And then last but not least, I'll just say this because I think this is really important, governance. So when 5 implementing partners need to push data into a consolidated repository specific to a PEPFAR initiative, the real question remains, whose data is this? And is this a national system? Is it a PEPFAR specific system? I think we're grappling with this as a donor agency to ensure that we're not sort of building, again, data acquisition pipelines just in service to a PEPFAR program or in service to a particular bespoke initiative. I think the big corner that I think we're going to need to turn is thinking about not community-based data collection, not as something specific to an initiative, but actually something that host government should be owning and managing and governing over time. So I'll stop there. There's just a lot to talk about. I want to make sure others can talk. Over.
Yeah, no, these are all really great points. I wish we could spend an hour just talking about that. But just on your last point, Jacob, it also, system ownership. When you have 5 different implementing partners implementing a system on behalf of a mission agency, that then means that no one really owns that systems and is therefore responsible and accountable to the integrity and maintenance of the system. And it becomes really complicated to manage that across different organizations who have fluctuations in technical capacity to do that. Mark, I'm going to turn to you because this year, was it this year or last year, you launched the male circumcision adverse events tracker module. Congratulations. For those of you who don't know what the male circumcision adverse event tracker module is, Mark's going to explain a little bit about that. But Mark, tell us, what was the thinking around using Datum specifically to collect this critical data?
Yeah, thanks, Nicola. I do just want to acknowledge that the brains behind this, they're in the audience. So Sarah Cyril, Ben Giraldi, others were very much involved in delivering on this. And this was a stretch project. It's not something we had budgeted for, but it's something we really saw as a need. And essentially, you can kind of surmise from the title. PEPFAR has primarily we're testing and enrolling individuals on lifelong treatment, but we also do have a surgical program where we are doing voluntary male medical circumcision. And as with any sort of surgical procedure, there are times when there are adverse events, and we have requirement to report on those. Those reports can often contain a lot of sensitive information about the beneficiary. That could sometimes include sort of graphic images and other things that were previously emailed back and forth, and they could sometimes be email is not particularly secure if it accidentally gets forwarded or whatnot. And so we were really approaching this on the system side as this is a concern. Our program colleagues had really said we're concerned about one, how we're managing these data, and two, just the potential for these particularly sensitive data being leaked. And so we already, one of the things we had to do very early on within for adopting the DHIS2 platform was to go through a federal authorization to operate process. And so this means that in that process, we are cleared to process different sensitivities of data. And we do have an authorization with that environment to bring in these sorts of private, personally identifiable information. We just felt this was the right process. It was the right thing for us to do. It wasn't something that our leadership was begging us to do, but we really did see this as an opportunity to use functionality that was already available to us with an authorization boundary that was already approved to allow us to process these data. We also did it in a way in which we can reapply this pattern to additional adverse event reporting. We're looking at doing this for our cervical cancer program and others. And again, this is just ways where I think when we really were starting with this, it was playing whack-a-mole with every single request that was coming in with leadership. And there were so many use cases that we would very much like to pursue, but we just didn't have bandwidth. And this is just one of these where were it not for Sarah Cyril, who came in after you, Nicola, as our product owner for the Datum platform, has just brought such tremendous experience as an implementing partner directly in the field, experience using the platform really to help to highlight the different areas of functionality that we can apply to use cases that have really existed for quite a while. So it's been, it has been good. I will say we have had to hit the Lars button on this because we did just do a core software upgrade and it did break our adverse events functionality, but we are working on it and we know that there's a good escalation path there. Thank you.
My heart is all aflutter, with all of this. That was one of my greatest, I think, achievements, was putting Sarah in my position, frankly. Sarah is doing an amazing job. We are so proud of her. And, congratulations on getting this out the door, Mark. I know what it takes to get it through. So this was a big one. Okay, so I'm going to shift over to Michelle, because while you guys don't necessarily work directly with Tracker, you do things that are somewhat Tracker related. So Michelle, why don't you talk to us a little bit about the WHO SMART guidelines and anything else that you want to tell us about?
Yeah, so, well, in a way, we do a lot with Tracker because, as I mentioned in the beginning, so many countries are deciding to use it for their HIV, TB, and or malaria and C19 patient level systems. And they are requesting, so those national programs are requesting a global fund through the country grants to support that. So again, because of that, we then also have some core support to try to make sure that there's efficiencies created across the countries. And yeah, one of those is talking about the different ways to have standard starter packages available, and we have them through WHO, Global Fund, others, including PEPFAR, CDC, Gavi, have supported pieces of these. But the WHO has done software agnostic facility data analysis guidelines and curriculum, and then based on that, there have been DHIS2 packages put together of if you wanted to follow this analysis guidance and use the WHO standard indicators. Then this is you can do the data collection forms, or you can also just take the dashboards and the analytics piece, and that's for aggregate. But when it comes to Tracker and patient level systems, of course, there's actually even more need on that to say how can we make sure, regardless of the system, the software used, that the normative technical guidance, both the programmatic technical guidance and the SI technical guidance about the indicators and how the monitoring evaluation should be done for patient level care and for case surveillance, making sure that those normative guidelines from WHO and some other technical partners are built in correctly into digital systems. So WHO has both the initiative on SMART guidelines, which PEPFAR and others are also supporting in addition to Global Fund. And that is to really translate these normative guidance from paper into the components that software developers need in order to develop the software. So that you don't have those software developers having to come up with that technical programmatic translation themselves. So then, in addition, also supporting, and that puts those pieces out there for any software to use or any developers to use. And it creates a lot of efficiencies and a lot of improved quality of these systems to take care of patients and to report complicated indicators from patient level to aggregate correctly. So we've been really supporting that for HIV, also starting to support it for TB now as well. And then in addition, we have the piece around, and it actually was just launched yesterday, WHO launched the beta version of the DHIS2 WHO HIV case surveillance tracker package. So basically, yay. And they are at the same time, well, in a week or two, going to be launching the SMART guidelines for the layer 2. If you go look on the SMART, we'll put the link on there, SMART guidelines for HIV case surveillance as well. And so that gives us, for us, that's a big thing where the countries can take these, either like the kits that are software agnostic, or they can, if they know they're using DHIS2 and want to use that for their case-based or patient-level systems, they can take these packages and start with them and already have standard indicators, have these patient flows based on the programmatic guidance and indicators calculated correctly. And then as they need to, they can then adapt it and change it to what, from their starter packages, obviously, and they can go and then adapt further as they need to. So that's something that we're really looking towards supporting implementation of that. And that can be for existing systems to try to better get the WHO normative guidelines in there and get standardized, and which facilitates reporting up, and also for those putting out new systems. So it's exciting that those are coming out.
Very exciting. Very exciting. We're gonna shift gears. We're gonna move on to the next question. So COVID has been a major disruptor across for everyone on every single level. But in some ways, it's been a positive catalyst for digital system development globally. Lars actually remarked earlier in his welcome remarks that, the pandemic actually really accelerated some of the tracker and Android development because these were such critical pieces of the digital public infrastructure in the national COVID response around supporting a rapid deployment of the COVID metadata surveillance and vaccination packages. Similarly, the HL7, who is responsible for the FHIR standard, recognized the need to further accelerate the international adoption of FHIR, and highlighted the pandemic being a major event that really refocused their efforts to do this on this front. Their 2020 annual report, which if anyone is interested in, we will provide a link, actually highlights a 5-part strategy to doing this, including increasing the number and depths of partnerships with global and regional organizations such as the Global Consortium for eHealth Interoperability, the Gemini Project, the World Health Organization, Pan Health Organization, World Bank, et cetera, et cetera. So we've seen DHIS2 and FHIRs are examples of globally established digital public health infrastructure that have demonstrated an ability to deploy and scale rapidly in the face of catastrophic events. I want you guys to think about how has this pandemic actually affected your agency's thinking about prioritizing these types of solutions, not necessarily not just in the face of the existing pandemic and what we need to do right now, but also more from a preparedness perspective when the next big global health event hits us. And I just want to remark in the Mike Frost session about the COVID metadata package, he had this really great quote, a crisis is not the time to build new things, right? And that came out of the lessons learned from the Ebola crisis. And so let me just go around the room here and see what you guys have to say about that. Jacob, I'm going to start with you.
Sure. I'll lead off. I mean, I think, as an agency and as a bureaucracy, I won't speak for any other stakeholders here, but we're a bureaucracy at USAID, and, for good reason. But when you think about something like the COVID-19 pandemic, it shows up, and I think disrupt is the right term here. I think for our discipline, early on in the pandemic, one of the biggest questions was, what systems should we be leveraging? How do we move this forward? How do we advance and, provide sort of a nimble approach? Nicola, you described, I know Merrick Schaefer, one of my USAID colleagues, has been very outspoken based on his lessons learned with Ebola, was when you start from scratch, developing something from the ground up where your practitioners, your end users, your clinicians, all like your entire, HRH, Human Resources for Health, has to learn something entirely new just to count new beans. That's a real problem. And so, I think it should go without saying that there was a big push for leveraging what already existed and what already, had reached general maturity in country very quickly. And there was also probably no immediate donor funding for host governments to just sort of, come up with this magical new solution. I will highlight, and I'm going to use, this is the COVID-19 map and match work and activities. So I think some folks may be aware that USAID, but not exclusive to USAID, Gates Foundation also provides financial support, and even Mark DeZelia through State Department is also funding and supporting the Digital Square project. One activity that, again, my colleague Merrick Schaefer and Adele Wagaman had really championed was this idea of mapping and sort of mapping the landscape of digital health systems in countries, and then kind of matching them up to sort of capabilities and profiles like contact tracing, case management, et cetera. I'll drop the link in the chat, but for those who haven't seen this, it's actually quite illuminating. I think there are about 25 country profiles and then 130 countries where they did sort of a broad-based review of all the different systems in place. I think I would just say, lastly, is DHIS2 the absolute best implementation for COVID-19, case reporting and mortality, sort of death reporting? Maybe, maybe not. In my mind, it's really, what are you able to do quickly in order to adapt and sort of, build out your systems? And so, I would tend to agree with your characterization and Lars's characterization, Nicola. But I would just say that in some ways, it's not even about DHIS2 or not. It's about how do you actually make sure that host governments are prepared through whatever infrastructure they've built up over time. I'll stop there.
Yeah, exactly. Could not agree with you more. Mark, I'm going to turn over to you. What have been your thoughts or the agency's thoughts on this?
Yeah, I will say, just to echo everything Jacob said, learning from the Ebola response and painfully seeing some of those same mistakes being made, like looking for new bespoke solutions to ramp up, has been really painful domestically as well. And I think on a very personal note, it's I think a lot of us probably became a little bit more emboldened in advocating for or just executing on what we really think are the right things to move forward. And a lot of that is we shouldn't be reintroducing the wheel every single time we need to start up something new. I think there is something to be said for the right solution. It's not always, but it's good to start with what you have. I would say beyond that, though, it really has helped us to start up sort of an activity that builds upon the map and match activity, and it builds on what WHO has been doing with the Digital Health Atlas. And it's just PEPFAR we're starting with a pilot this year, and then across the majority of our operating units in FY22, we will be doing an annual inventory of the digital health investments that are being made by partner in country. And I will just say, in my many years supporting this program, it's just, to me, remains one of the biggest blind spots we have, is that there's just so much anecdote about what we're investing in, because like Global Fund and like World Bank, we are decentralized in some ways, but we really could benefit from a little bit more central strategy about how we're building and supporting systems. And so we're really trying to move from anecdote to evidence and how we are supporting country teams with how they're building and supporting systems. And of course, that will involve DHIS2, but there will be a lot of other things out there. And we can't really be talking about interoperability unless we know what those lowest common denominators about the systems are there. So COVID has really, to me, just given me more confidence to follow my gut, lean into what we know works, and to be a little bit more bold in the way we tell leadership what we think should be the right ways forward.
I have a quote from you, Mark, that said, sometimes the right tool is the one that is most readily available, accessible. So thank you for that. And okay, Joaquim, we're gonna go to you, and then we're gonna keep moving, chugging along here because we've got 10 minutes left and 3 more questions.
Yeah, no, so really quickly, I mean, I agree on the most of the things that Jacob and Mark have mentioned. And you know, the bank's focus has been on, and we've been trying to, you know, make sure that, you know, things that are already on the ground are prioritized. But also the bank's focus on COVID has been to strengthen the health system. So yes, this is a COVID response, but really, you know, and you know, you need to make sure that the health systems are stable enough to be able to, you know, and prepared enough to respond. You know, I do agree that, you know, pandemic prepared, you know, if you're trying to do something, you know, during the pandemic, I mean, it's, you know, it's not going to work. And then in terms of future, I mean, I think the one thing I'm excited about is potentially, you know, figuring out ways to have patients interact more with their healthcare, so scheduling care, being able to, you know, I mean, take what now we have to do with, you know, what vaccines does very well, but, you know, try to expand that to the rest of the healthcare system as we have. So, yeah, I mean, I think those are kind of the big things that at the bank right now.
Yeah, I mean, it feels like we've reached the point of no return from before days, right? Like before days, we're not coming back to. Like, this is unfortunately the reality. And the funding, the mindset probably needs to shift in that sense to ensure that national systems have even the foundational pieces that they need to be able to respond to anything. All right, so there was a question that actually came in that actually ties into our next question very nicely. So how do you feel like the alignment with DHIS2 has really helped align with your government, your implementing partner systems? Have you seen this alignment play out or not? And there was a broader question about, you know, regarding interoperability and metadata alignment. How can donors help cross collaborate? And this goes to our second part of this question about donor alignment, to really help increase the adoption of these standardized indicators. Mark, do you want to take that one first?
Yeah, and I'll try to be really brief, but it's just, I think in the minds of people who don't spend as much time as we do thinking about data and systems, I think interoperability can oftentimes just be confused with DHIS2. I've heard it more times than I can count, and that we don't understand why these systems can't communicate because they're all using DHIS2. And so that gets back to what Jacob was talking about: governance, about structured data, and about thinking about a larger architecture for the systems in country. I cannot imagine a future in any of the countries we're supporting where DHIS2 will be the entire game in town. There will always need to be an interface with a BI tool or another data collection tool or a warehouse of some sort, and just making sure that we have the right patterns and the right sort of support and experience to share with others as they approach it, I think is critical.
Absolutely. Joaquim, I'm going to ask you, where have you seen this alignment play out?
Well, I mean, yeah, I mean, I'll also say the exact same thing, which is around interoperability. And I mean, I think it's the biggest thing, because a lot of countries are asking for it, but they don't know what they're getting into. but also, and I think this ties back into Tracker because, yeah, I do think that DHIS2 needs to, has been playing fairly well, but needs to play better with other with other systems, and specifically, it was mentioned around Tracker, but specifically around, where's this line where Tracker is an efficient tool versus what Jacob had said before around case management tools, ComCare, OpenSRP, Community Health Toolkit, which have a lot more functionality for community health workers, for health. And so I think, the one negative side that I've seen to Tracker is that, it does, from the outside, it does feel like DHIS2 expanding into, into other areas where it's not as good, and taking over area, projects where other tools are more prepared. So anyways, so coming back to the interoperability part, so I think making sure that interoperability is really plug and play, I think is really going to be essential.
Okay, anyone else want to jump in on this? Otherwise, I will go on to the next question. We got about 8 minutes left. All right, so this was a big one that we were talking about earlier. The future of standard metadata packages. What does that look like for your agency? Michelle, I'm going to start with you because obviously you guys have already started this work. Why don't you talk a little bit about that, a continuation of what you guys are doing?
Sure, thanks. Well, I think key things are to continue to update and adapt them based on actual use in countries, because we still have to make sure that they're meeting the needs in countries. Otherwise, even if it's nice that they've got the right guidance in there and they have the right indicators based on the kind of global guidance, it needs to be something that countries really want to uptake and find useful. And in most cases, that has been the case so far, especially once they then adapt as they need to for their own systems. But we need to keep feeding back the country experiences into this, and especially once you get with the facility level metadata packages. The second thing I would want to mention, which is a little bit different, but just an interesting time, since this might, I'm going to say, probably be the last time I'll speak here. The thing I want to mention is creating in these metadata packages or outside of it ways for standard reporting forms for countries for the global reporting that they have to do. So this is something that we're exploring for Global Fund, and then so having a standard package for the Global Fund reporting, not just for DHIS2, but definitely starting with DHIS2 again, because so many countries using it, and then having ways for countries to directly submit their data from their national HMIS, usually DHIS2 based, to the Global Fund for their reporting, so that we're facilitating how they're reporting. And this is something I know WHO and others are looking at as well. So for us, that's an interesting new area that we're trying to explore to try to make things easier for countries on the reporting side, so that they can, so that the data are available globally and more timely to be able to be used, but also so, again, we can focus less on the reporting up and out and more on using the data in the country.
Yeah, that would be an incredibly powerful tool. I mean, the amount of time and energy that is spent creating these reports, Jacob, you said it best, I think. The mountain and pile of bureaucracy and level of effort to do that, to report out numbers, that would be, I think, a welcomed addition to the toolkit. Mark, I'm going to turn over to you.
Yeah, and I'll try to be quick here. I think absolutely standard metadata packages are critical. We are And again, it's on the system side, very supportive of the efforts coming out of WHO, and grateful that, you know, USAID and Global Fund and others have put a lot of thinking behind this. I think the real challenge that I see is convincing our program colleagues to adopt this, because it does change the way in which we gather requirements, we codify them, it changes those timelines in some ways. And so that will be some internal behavior change. But I think we really just need to highlight the inefficiencies in the way in which we release narrative guidance right now. I do just want to, I'm cognizant of time, just add 2 points that we don't have to dive into, but the governance around ownership of data is only going to be more important for all of us. There are 2 complementary efforts going on right now for a Transform Health Coalition. They're developing health data governance guidelines. WHO, the second of 2 summit events is this Thursday. You can look that up if you want to join, but they're really looking at setting some standard global approaches to what you should be considering in health data governance, and making sure we have those right data sharing agreements is going to be important, and making sure we're putting more of the burden back on us, on Global Fund, on PEPFAR, on WHO, particularly as we're thinking, I've heard WHO say multiple times they want to be the repository of all health data. What that actually means in practice and how that feeds other sort of reporting needs is going to take a lot of thinking. And I think we just need to be careful about knee-jerk reactions there. Over.
Okay, so, all right. So somebody has thankfully put that information in the chat. Mark, if you want to share any information in the chat for folks to join that event, that is most welcome. And finally, Jacob, your thoughts on this. We have about 2 minutes, so we'll try and maybe we'll end it here with your final thoughts, Jacob.
Oh gosh, because I was just going to say ditto to what Mark was describing. I actually did. So Vidya, my colleague, actually beat me to the punch. But I think we're actually evolving in this space from a how do we get the data into how are we starting to use it responsibly, and also really, you know, beginning to reflect back on what's necessary. You know, I think, you know, we haven't gone to 2-year age bands yet, Mark, in PEPFAR. Although we are, you know, still consistently pushing the envelope around, you know, what types of reporting we expect or need. And I think what I'd really love to see in the next 5 to 10 years is sort of a recession or a receding back from the idea of gathering more and more and more, and instead being a lot more responsive to what are we looking at and what do we need. I think a lot of that is going to be driven by the ability of individual level data collection systems to refactor indicators. This is, again, smart guidelines, level 2, all the things that Michelle has been talking about and Mark and Joaquin have alluded to. I think this is sort of the big picture of how we not break the backs of ministries of health in service to a broader, you know, digital and, you know, data ecosystem in country. So I think there are a lot of opportunities come up that are coming up. I encourage people to join that WHO Data Governance Summit session, because I think a lot of the issues around this public health data as a global public good will really bring up these questions of what do you need in country? How are you going to secure and protect that data? And also, you know, really sort of getting away from what's the one solution that's going to make everything work, and instead sort of describing what's the, you know, the tapestry that we need to actually build out in country to ensure that we have the ability to flex, be nimble, but also have the robustness to be able to support all of the data needs, not driven by me, but driven by what a minister of health or a permanent secretary is really asking for on his or her desk on a monthly basis or even weekly basis. I'll stop there.
And I'm going to land on a final thought to Jacob and how donors can help fund holistic ecosystem architectures. I'm not here to point fingers at anyone, but in order to move national systems forward, it has to be holistically funded from end to end. And with that, I am so thankful to see you guys. It has been great to see your faces. It's been way too long. I really hope that we get to see each other in person someday. Thank you for joining us this afternoon. And we will see you soon, I hope.